So talking about an unusual topic to a non-military conference, but Dr. Backus wanted me to kind of give an overview of being a military otolaryngologist, training, what we do, any unique facets to our lives. And then I wanted to try to give a little overview of that to maybe share some programs that we are affiliated with that also you can partake in as well. Because I'm in the military, I have to tell you, these are my opinions. These do not represent the Army, Madigan Army Medical Center, Department of Defense, any organization that is above me. These are my thoughts. And I'm going to give you the down and dirty scoop on everything here. So let's do a little thing here. Can you raise your hand if you are currently active duty, were active duty in the reserves, National Guard? And then keep your hands up if you have anybody in your practice that is any way, shape, or form affiliated with the military. Then raise your hand if you are never going to raise your hand no matter what I ask. I usually get one. There's a couple there. Okay. Well, this goes to show you we're kind of an unusual world. And so my hope is that we can shed some light into this esoteric thing that people may not know. And if you know where that's from, that dates us all. But also, this is not a recruiting pitch. Let that be known. This is not there to entice people. But I want to add some insight in what we do. But also, maybe you have undergrads, medical students, residents, fellows, faculty that are curious. And that way you at least know the pipeline of how we get into the military, and then unique stressors that we have and some unique opportunities that we have, and then how do we transition out. And we kind of have a blended world sometimes. And so to do that, I'm going to talk about this, how we get in, where we train, stressors that some are ongoing and some of them are new, and then opportunities that we have. And then, like I said, share some, at least some ancillary programs as it relates to auditory and vestibular opportunities, training, research that can also be paired maybe into your practice. And then just transitioning out, and that's maybe another way where you see us as we're kind of dabbling in both worlds as we leave the military. Everybody knows how to become an ENT. Obviously, we go to college, medical school, residency, fellowship, maybe, and then you're an attending or staff somewhere. Each of these steps have programs to get into the military. Many people do ROTC. I think we're familiar with that with undergrad. You can go to a military academy. Each of these have different obligations. Basically, if the military pays for something, you pay back with time. And all of those owe technically 8 years, but 4 to 5 of them are active duty, and then whether or not some of the residents know, you have this IRR time afterwards that has to add up to 8 years. So meaning when you do separate, not really, you're on a list somewhere. So if, heaven forbid, they have a recall before we do a draft, and I hope we never do a draft, but before we do that, everybody on the IRR list gets sucked up first. So all of the other outsiders, if you see the IRR people get sucked up, you know something's coming. No, I'm just teasing. But it makes sense because they're going to pull people in instead of retraining somebody from the start. No, they at least pull people in that know the lingo, that are familiar with the organization. Medical school, this is where most physicians enter the military. They pay for medical school. And it's usually the health professional scholarship program, 2 to 4 years. Most of them are 4 years. So if they pay for a year, you owe a year. The Uniformed Service University, so the military has a medical school in Bethesda, Maryland. And so the DC area is where the bulk of their training is, but their clinical years are scattered throughout the military hospitals all over the world, really. And they owe 7 years after that. And in residency and fellowship and attending, they have a financial assistance program. So if you just say, I want to join the military, you can go and say, forgive my debt. So how much debt they forgive, they'll do some military math and figure out how many years you owe. Or you can just do a direct appointment and say, I don't want any strings, no money, I just want to join. There'd be some commitment to serve a few years. So entry points for that. And if you talk to all of us, we all have, that's why a lot of us have different obligations. It depends on where in the pipeline we came in and what the military paid for and what we signed up for. There are 6 otolaryngology residency programs in the United States for the military only. One of them is right here in our back door in Tacoma. Joint Base Lewis McChord is Madigan Army Medical Center. So you may hear people say Madigan. It is solely an Army training program. There's one in Honolulu, Hawaii. It's solely an Army training program. San Diego is only for the Navy. Portsmouth is only for the Navy. And then the Air Force only has one in San Antonio, and that's a hybrid one with the Air Force and the Army. And then the Walter Reed Bethesda, that is the joint Navy and Army program as well. So it used to be Walter Reed Army Medical Center and Naval Hospital Bethesda. Lots of politics over the last decade or so merged things together, and now it's Walter Reed National Military Medical Center in Bethesda, and that's where the Uniformed Service University, the medical school is for the military. So that's where we train, and then we can, and so if you're around any of those locations, you may interact with some of the residents, and thank you for helping teach them. Challenges. Now, I'd be remiss to showcase some of the challenges that we have. Staffing shortages. This is an ongoing thing all over the country, and we talked a little bit about it as well with efficiency, but, and COVID didn't help this, but our big thing is deployments. The military, so whenever you see the headlines of the military set up a field hospital in a stadium somewhere, we have the capability. So the purpose of the military medicine has many hats. And so we often have these many cooks in the pot that pull us in different directions. So not only are we otolaryngologists in this case trying to take care of patients, we also at a moment's notice can go and set up a field hospital somewhere. So within less than 3 days, in the middle of a field, the military should be able to set up a massive hospital with an ICU, with surgical capabilities, with CT scan, you name it, it's there. And then also the smaller referral areas, the forward hospitals, or the different roles we call it, closer to the front lines, set up hospitals and scatter there. Those people come from places. Those people may be in your hospitals as reservists or National Guards people, or they may be active duty. So whenever you see one of these pop up somewhere in the news, that pulled from something. And often it pulls from the active duty hospital. And so then our capabilities drop immensely, and that's stressful. One, taking care of patients, but also teaching residents. Frequent turnover of attendings. It's nice to build a department and keep that department and grow that department. When you have little ability to hire and bring people in and everything is centrally controlled and the military moves people around every few years, there's a dynamic that is stressful. We have a fixed patient population. We can't hang a shingle out and say, we're the best at this. Please come to the center of excellence for, you name it. We have the TRICARE patients, and the patients that are in our region are the ones that get referred to us, and then they move away, and then they kind of come ebb and flow. So we have technically a fixed patient population. There's a transition in military medicine right now. So instead of having Army, Navy, Air Force hospitals, instead of having that overlap, on a bureaucratic level, merging it all to the Defense Health Agency, kind of a blended medical piece. And that transition has some growing pains with that, and different levels of red tape, some shrinking as well. So and to not simplify things too much, to say like I said, there's competing interests. The hospital's trying to run a hospital to take care of patients. GME is trying to run and teach residents to train the future of military medicine and follow ACA GME standards and make safe, good, educated surgeons and leaders. But also the National Defense Authorization Act is saying, decrease military medicine a little bit. What do we need to have for the military hospital, and what can we send to the community? So you may see an influx of TRICARE patients in your region, as maybe the hospitals in that area are shrinking or redirecting their capabilities or changing their capabilities. So just know you may see some of those ripple effects with that. But all of this can lead to decreased case complexity and clinical volume, which is stressful as people trying to maintain their practice and teach. Despite all this, we are blessed with many opportunities, and the biggest one is the South Sound area. We are fortunate. This is a huge area of wonderful medical facilities and wonderful faculty. And so many of you in the audience help teach and train our residents and have a working relationship with many of the staff as we live in worlds where we work in the military hospital and maybe spend time in civilian hospitals to keep up our case volumes and also make sure our residents are cared for and our patients are cared for. So thank you. When you share knowledge to a resident, you're a force multiplier. That resident is going to go who knows where. They may be the isolated person in Alaska or Italy, the stresses of being in wonderful places. But as we tackle our cases, I often hear the voices of my mentors in my head. Thank you for being those to our residents as well. We have a large referral region. So although we're in the Pacific Northwest, we have military treatment facilities in Alaska, Japan, Guam, South Korea. The Pacific Fleet is all over the place, and they refer people back to the big teaching hospitals. And so although we can't recruit and have patients come seek us, just by the nature of the referrals patterns, we get consults over a large area. That can take different shapes. I remember as a resident, I trained in Hawaii. I remember as a PGY2, I'd answer the page and it would say, this is the USS whatever, we've broke radio silence, we have 30 seconds, I have a question. And they would ask a question and I would say, I hope I answered it correctly, because the submarine went back underwater, and then I'd call my staff and they would say, you managed that poorly and we have no way to get a hold of them. Or they would say, hey, I have this bad otitis externa, whatever, do we need to elevate their care? And I was like, yes, elevate their care. Little did I know, I just moved the Pacific Fleet to break their training to come to the hospital, because this person, according to the specialist, needed elevated care. So it kind of makes you learn a little bit to be resourceful, really think your actions can shape a lot of other things. And so it adds a dynamic of stress to the residents. I'm looking at the residents right now, because it may not just be an ear infection, it may be the Pacific Fleet. No, but we don't have insurance, like it or not, in the military hospital. That's a great stress reliever for me, but also adds is a reminder when I balance into the civilian hospitals and have to do peer-to-peers and get approval and pre-authorization, everything that you deal with on a daily basis. And the nice thing about it, despite all the red tape we have, despite all of the hurdles and paperwork we have to get and obtain things, if somebody needs a cochlear implant, they get a cochlear implant. If somebody needs you name it, to purchase anything, it gets approved. And so that is one nice thing with that. We have unique treatment needs. So Mission Essential also shapes some of our practice. And that's sometimes stressful for our residents to grasp if we say, here's the algorithm of this disease, but then a commander comes in and says, hey, I have the Special Forces person. They have difficulty popping their ears, and we're leaving in an undisclosed amount of time, and I need them to be ready to do their mission. We say, okay, we'll script everything and put a tube in. Or can they put a tube in? Do they have water exposure with their mission? Is that duty limiting? So you have to be aware of the unique demands of the patient. If they're on a submarine, you can put a tube in, but if they're a Navy SEAL diver, maybe they can't. So you have to have this nuance, and we sometimes skip some steps or waiting or trials or medical trials just to get them back to do their job for the mission. So that adds a variable to things as well. And most of the time we have no insight into what that is. We are the helpers to keep people going. And then manning assist requests. As these clinics in outlying regions, they don't have the specialists. So they may say, hey, it's cheaper to have you fly over and do these surgeries rather than have everyone move back to, get reassigned back to the United States to recover. Can you come? And so we'll set up, otology weeks. And I was fortunate enough to be able to do that in Germany a few times, and a lot of us will ebb and flow into these different locations. And I think these are often opportunities that the burden, unfortunately, is on us, the surgeons, to make your skills known and showcase what you can do, and ask your colleagues out in remote areas what they need. Be available, be helpers. And I think that pays dividends. Our residents in residency have some unique things as well. In addition to all of the experiences that we need to do to fulfill ACGME requirements and case numbers and academics, we send everyone to the Combat Casualty Care course. If you're used to, a Bushmaster, that's a kind of an immersive experience where they get to be a field physician in a combat simulated setting. Our chief residents have a capstone course where the Joint Base Lewis McChord puts together the simulated battle that has patients, and the field medics and other organizations outside the hospital get to partake in that. And the residents scatter across these tent hospitals or field hospitals that are set up, and they fill into their normal roles. The internal medicines are the hospitalists, the surgeons fill their surgeon roles. And then the patients come in, walk in, military ambulances, air evacs, and so they get to practice their skills in a setting of lectures and then hands-on. So it's kind of the capstone course to remind them, although you've been in a sterile hospital setting for 5 years, you still need to be able to flex your muscles to respond to humanitarian crises or missions. There's also opportunities as a staff I found as well. So as case volume ebbs and flows, and the military is great, I've learned. I used to volunteer for lots of things. Now I like to wait until I'm voluntold to do certain things, because the military is great at that. And there's humanitarian assistance courses out there, Joint Hyperbaric Medical Officer and Technician course, the former Army Dive Medicine course. that's actually up here in Seattle. NOAA's headquarters has that, and it's a group of military and civilian partnerships with that. What I wanted to showcase that's maybe relevant to the audience is we have a hearing center of excellence, as many roles, because hearing loss is one of the hearing loss and tinnitus are the #1 diagnoses of our service members when they get out of the military, and it's one of the largest disabilities. We have a large network of healthcare providers, military and civilian, that have the Collaborative Auditory and Vestibular Research Network, CAVERN. Look it up. Maybe there's one in your area. They bounce around to different locations every year. You can join our monthly journal clubs. It's on Thursdays, working groups where we share articles and talk about traumatic brain injuries and audiovestibular issues. Military Vestibular Assessment Rehabilitation course. They have a basic and an advanced course with great online content. I'll give you a link to that at the end. Where there's great videos on just vestibular diagnoses and clinical assessments. Lots of research areas across the country. Spatial disorientation is huge in the military. It's the #1 cause of catastrophic injury and loss of millions and billions of dollars worth of equipment. And so Navy Medical Research Unit in Dayton has Wright-Patterson Air Force Base. They have the Kraken, the spatial disorientation machine. You're going to get seasick in that. Spin around in this mock cockpit. But if you want to look at that, Fort Rucker, Alabama has a lot of this as well. Battlefield Acoustic Chamber. Not only is that studying the efficiency of hearing aids, but also like the sniper sniffer, like using AI to listen to a bullet flying by and immediately can know where it's at, where it came from, and how far away. So there's lots of things on and off the battlefield. Research opportunities. Congressionally directed medical research program is a hearing restoration rehabilitation that we're affiliated with, where we look and see a lot of civilian grants to see who we want to fund. And this can be a lot of the downstream pathways that are disrupted for auditory injuries, both traumatic and ototoxic, and then the rehabilitation and regeneration techniques with that. So if you have any insight into hearing auditory vestibular research, there's usually a way to make that relevant to the military and may open up a lot of additional grant opportunities for you. When we transition out of the military, it's not like we say, all right, my time's up, I'm done. We have to apply to get out of the military. And so that's a sobering thought to many of us. And so about 12 to 18 months in advance, we say, I'd like to get out. I'm putting my notice in. It goes through all the things. They could say no. And it's called stop loss. They might say, we don't know. There's a lot of threats out there. We need you. So you're stuck. They could recall you. And that's what I talked about before. Even though you get out of the military, there's a few years where you're kind of on a list. The Skill Bridge program. So you may see some of us come to you and say, hey, I'm getting out. The military lets us, while we're on active duty, the last 6 months of our practice, to say, hey, I've been in this environment, my case volume is a little low, can I work for you, free of charge, where I can be immersed in this experience to ramp up, or to maybe make up for a deficit that we've had. Just know those are things that you may hear people talk about. My concluding slide, just to make it relevant to the audience, these are websites I encourage you to go to. The top one is probably the most relevant. It's the Hearing Center of Excellence, has their military vestibular assessment rehabilitation training videos. There's a bunch of links at the bottom, and each of those go to a YouTube channel with even more links. Those are bread and butter basics. So the military is great at vestibular rehabilitation, and we should be wonderful clinicians with that, because we see a lot of unique vestibular pathology, especially with blast injuries and percussive injuries, mix of peripheral and central. And so I always want every otolaryngologist that comes out of a military training setting to be savvy with that. But they have great insight into bedside clinical exams put together. You can have your audiologist look at this as well. You can have your physical therapist. Vestibular therapy is something that's tough as well, so you need to be savvy on what a good vestibular therapy program looks like for your patient. And this can be a starting point for you if you want as well. So hope that was somewhat of an overview on an interesting topic. Take any questions? All right. Thank you.